Good afternoon. I'd like to welcome everyone to today's webinar presentation, Effective and Compassionate Communication for Informed Shared Decision-Making. I'm Lynn Osborne, Director of Business Development at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. The Schwartz Center for Compassionate Healthcare is the only national nonprofit dedicated to nurturing patient-caregiver relationships to strengthen the human connection at the heart of healthcare. Before we begin the formal presentation, let's go over a few details about the webinar. The Schwartz Center Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 60 minutes. The first 45 minutes will be presentation, followed by a 10-minute question and answer session. Today's program is being recorded and will be available on the Schwartz Center website a week after the session. Please note that attendees are participating in listening-only mode, but can interact with the speakers and me by using the questions pane, which should be appearing on your screen. If you have questions, please just type them into the questions pane and send them to us, and we will address as many of them as we can at the end of the formal program. We'll also be polling the audience during this session, and we hope you'll participate in this measurement tool. As you exit the webinar, you'll receive an electronic survey that we ask you to take a minute to complete so that we can capture your assessment of today's program. Your feedback is really important to us. And now it's my pleasure to introduce my colleague and our host for today's session. Dr. Beth Lown is an Associate Professor of Medicine at Harvard Medical School and the Medical Director of the Schwartz Center for Compassionate Healthcare. Beth?
Thank you, Lynn, and good afternoon, everybody. Today's webinar is going to be really interesting. It's about shared decision-making and offered by two of my close friends and dear colleagues. Shared decision-making is a complex topic. Most of us who work in healthcare have not really been formally trained in the specific communication skills required for it, but to really provide patient-centered care, those of us who do provide care must be able to probe and understand patients' unique circumstances, values, and preferences in order to really help them arrive at a choice that fits his or her individual needs. So this webinar will teach us how to elicit patients' preferences, how to communicate risks and benefits effectively, and how to recognize and help patients resolve decisional conflict. So now it's my pleasure to introduce today's speakers. First, Calvin Chou, MD, PhD. Calvin is Professor of Clinical Medicine at UCSF and a staff physician at the VA Medical Center in San Francisco. He received his MD at Columbia University and completed his residency training in internal medicine at UCSF. He is a faculty member of the American Academy on Communication and Healthcare and is nationally recognized for his efforts in education and research to enhance communication between patients and physicians. Calvin actually holds the first endowed Academy Chair in the Scholarship of Teaching and Learning at UCSF, and he has delivered communication skills curricula for providers across the country. He is also the co-editor of a book on remediation and medical education, which was just released in January last year. Welcome, Calvin.
Thanks, Beth. It's really a pleasure to be here today.
Thanks, Calvin. Also today with us is Nan Cochran. Nan is Associate Professor of Medicine at the Dartmouth Institute for Healthcare Policy and Improvement, and she's a Fellow of the American Academy on Communication and Healthcare. Nan developed Undoctoring, the interviewing and physical diagnosis course at Geisel, and she received a Schumann Fellowship in 1999 to learn and to teach motivational interviewing, which is where we first got to know each other, I think, Nan. Nan's done research on how to integrate shared decision-making into primary care settings, how to teach it to clinicians and students, and she has recently studied negotiation at Harvard Law School. As a faculty member and past president of the American Academy on Communication and Healthcare, she does a lot of faculty development and consulting in the areas of team building, negotiation and conflict management, motivational interviewing, and also shared decision-making. So welcome, Nan.
Thanks a lot, Beth. It's great to be here.
Well, we're all excited about today's program, so I'm just going to step aside and let you guys get started.
All right, wonderful. So I will lead us off, and let's start by moving on to the next slide, slide number 5, just to go over the objectives for the next hour. So we want to define shared decision making in case this is new to participants, describe briefly the evidence supporting it, which is very extensive, talk about how it is we ought to be eliciting patient values in all of our encounters with patients. Then we're going to talk some about risk communication, demonstrate how to use it, what the role of decision aids are in these conversations, and talk about the resources available and some of the barriers that exist to shared decision making. So moving on to slide 6. Just to define this, there are many definitions, but they all boil down to the same thing. The goal is to have a conversation with patients who wish to be involved in arriving at an informed, values-based choice when 2 or more medically reasonable alternatives exist. So given what we think about informed, there's got to be a choice, there need to be options that are roughly equivalent, and we want to be able to communicate clearly and easily about the benefits and harms of the different options, so those are understood by patients. And then the values is really critical, namely what is important to this patient in front of me. And I think the best way to illustrate this is to tell you a brief story about a patient that really had a significant influence on me in my practice. Her name was Priscilla. She's now died, but about 20 years ago, I was seeing her in the women's clinic, and she unfortunately developed breast cancer, which we diagnosed via mammography, and she came back in to see me. We knew enough about breast cancer at that point to recognize that for early stage breast cancer, there were 2 almost identical outcomes, 2 different courses of treatment that resulted in the same mortality, slightly different in terms of morbidity, side effects, etc., but that should be decided upon by the patient, because patients feel very strongly about whether they want to keep their breast, whether they want to undergo a mastectomy, whether they prefer radiation or not, etc. So I educated her about those 2 options, and she was incredibly clear about the choice she wanted to make. The most important thing to her was to keep her breast. So I offered to refer her to one of our surgeons here in New Hampshire, and because she lived in New York, she preferred to go back to her local community. I communicated with her local doctor, the surgeon who was going to see her, and he unfortunately told her there really were not 2 options, there was only one, and that she had to have a mastectomy. I didn't know what ensued at that point because I didn't see her back for another couple of months until she'd had the surgery, and she was utterly devastated by this experience and was clinically depressed. So upset by her mastectomy scar that when I left the room and asked her to change so I could examine her, she refused to do so. And that was such a powerful moment for me to realize that this patient's values had not been integrated into the decision. She hadn't been listened to, and frankly, the surgeon hadn't listened to her. So that was really a major turning point in my career. It made me realize we could do this better. We needed to do research and more training about how to do effective shared decision making. So that's really how I got involved in this work. So if we move on to slide number 7, you can see that shared decision making is supported by many, many organizations like the AMA, the AARP, American Cancer Society, American Board of Internal Medicine. Too many to actually fit on the slide, but I'm just giving you a sampling here. So this has been adopted in theory by all the major healthcare organizations. Turning to slide 8, I want to just take a moment to talk about variations that we see in this country in the practice of medicine. So this is a slide that comes from a wonderful resource here at Dartmouth called the Dartmouth Atlas for Healthcare. And Dartmouth researchers over the past 25 plus years now have broken the country down into 306 what are called hospital referral regions. So although you can't see it clearly on this slide because of its size, there are little dots representing each of those 306 areas. This slide is looking at the rates of back surgery done in Medicare enrollees. And if you look at the box in the upper right corner, you can see that there's roughly 5-fold variation in rates in those states and areas that are dark red versus those states that are pale or tan color. Now, it's important to realize that the Atlas has standardized patients by every means we know how. In other words, in terms of their age, in terms of their diagnosis, in terms of their comorbidities, in terms of their socioeconomic status. Everything we can control for was controlled before this data was analyzed. And despite controlling for all of those variables, you still see 5-fold variation in rates. And the question is, why is that? And what is the correct rate? Who's doing it right? Is it people in Florida? Is it people in Vermont? And why do we see such tremendous variation? As this wonderful Princeton economist Uwe Reinhardt says, how can the best medical care in the world cost twice as much as the best medical care in the world? And what he's really asking is, where is the best medical care being practiced? So moving on to slide number 9. The challenge is that even when we educate people, you're going to see variation, right? Some variation in healthcare is warranted, just as my patient Priscilla demonstrated. She cared strongly. Unfortunately, she didn't succeed in having her values honored, but she cared strongly about keeping her breast. A lot of patients with breast cancer don't want to keep their breast, okay? So there are variations in their attitudes towards treatment options. There are also variation in attitudes towards preference for participation, and we'll come back to that. People feel very differently about risk. Some are extremely risk averse and would not consider surgery. Others are happy to undergo it. So you're going to see warranted variation, and that's a good thing. We're not trying to get rid of that. Moving to slide 10, the challenge is that you're still seeing tremendous unwarranted variations. And why is this? That's because the information that clinicians are giving patients is either inaccurate, incomplete, or not understood. And again, back to Priscilla, patients' differing attitudes towards their treatment options, towards risk, towards health outcomes varies. And the challenge is that doctors are not listening to that. So if you don't ask about somebody's preferences, if they're unknown, or if you hear them and ignore them, then you're going to have unwarranted variation in what's called preference-sensitive care. And preference-sensitive care is care in which there are 2 or more roughly equivalent options in terms of the outcomes for a given healthcare decision. If we turn to slide 11, it was an interesting study done by a foundation called the Informed Medical Decision Foundation, which funded me and many others at Dartmouth to do research in shared decision making. They looked at all of their sites around the country, and there are roughly 20 odd of these, and you can see the total number of patients that they looked at was over 4,000. And they broke down the patients by age, by educational level, and by gender. And the question they were asking is, do patients really want to participate in this? Because as I teach this subject, I often hear, well, patients don't really want to do that, Nan. You're wrong about that. So here's some data on that point. So overall, you can see that patients want themselves to make decisions roughly 28% of the time, want to make decisions with their doctor 68% of the time, and want their doctor or other healthcare provider to make decisions alone for them 4% of the time. So 4 out of 100 do not want to participate in shared decision making. And if you go down to the subsequent rows, you can see that that number holds pretty stable. We used to say that those who are elder Those who were less well educated were more likely to ask their doctor to make decisions for them, but you can see the numbers are really between 3 and 5% across the board. So this is really interesting data, and patients clearly want to participate in shared decision making. The old paternalist approach needs to die. We move on to the next slide. So just to summarize, the forces that are sustaining the unwarranted practice variation that we see in this country, and it is true in other countries as well, is that patients are still forced to make decisions in the face of avoidable ignorance, namely if they're not being well informed by their clinician. And clinicians, unfortunately, are not good at diagnosing patients' preferences. So that's leading to what is considered poor decision quality and this unwarranted variation. So I'm going to turn it over to you, Lynn, for our first polling question.
Here I am. Thank you. Sorry, I forgot to turn the microphone on. Thanks, Nan. Our first polling question is coming up on your screen. We'd like our audience, our participants, to give us their feedback, which you can do on your screen. The question is, what % of the time do you spend doing shared decision making? So please select one of the following responses: 0 to 20, 21 to 40, 41 to 60, 61 to 80. Or all the time. So I'm waiting for these responses, and we're getting up there. A few more seconds. Okay, we've got a good response. Let's close the poll and see what we've got. And our audience replies with 11%, 0 to 20% of their time, 12%, 21 to 40% of their time, 19%, 41 to 60% of their time, 32%, 61 to 80% of the time, or all the time, 27%. It's pretty high. What do you think, Nan?
Well, that's a really interesting spread, and I wish we were asking this question again at the end, because once you see what's involved in the risk communication and elicitation of values, I'd be curious to know whether those numbers hold firm, because I personally thought I did it all the time until I really studied it and started doing research in the area and recognized that I was doing it very, very little of the time. So we can come back to this as a question at the end.
Excellent. Well, we may ask Kim if she can put it up again for us at the end if we have time. Thanks so much.
All right. So let's move on then to the next slide, slide 14. Which is not moving on my computer, but I'll assume you all can see it. So what this slide is talking about is what is a high quality decision. There we go. What would be, if you could just back off on that animated portion. Perfect, thank you. So what a high quality decision depends on is the patient having the knowledge necessary to be informed and to recognize what their options are and what the risks and benefits of those are. It also requires that the clinician have a really good understanding of a patient's personal values, what matters to them, which takes some time. We'll come into that now. And then it requires that the treatment choice that's ultimately made is consistent with those values. So it's concordant, as we say here. And what we're really looking for is a collaborative relationship between the patient and the physician, as demonstrated in that photo. Okay, let's move on to our next objective, which is how does one actually elicit patient values? What does this mean and how difficult is it? So if we go to slide 16, the decision obviously needs to take into account the provider's guidance and what the patient cares about. If you ask a patient, what are your values, what are your preferences, they won't understand those. Those terms are jargon. So typically we want to avoid jargon and not use those at all, and instead want to ask a question like, what matters to you most in making this decision? That's a question I didn't used to ask regularly, and now I ask it with every patient, every visit. And depending on how many decisions we're making, it may be several times during a visit. Turning to slide 17, let's look at how good doctors are at diagnosing patient preferences. Unfortunately, not so good. There was a study done in breast cancer, if we go to the next slide, that asked both patients and their providers, how important is it to you, they would ask the patient, or how important is it to your patient, they would ask the physician, to keep their breast. Again, we're back to the subject of breast cancer. And interestingly, 71% of the time, the providers thought that this was one of the top 3 considerations of a patient, that of course they would want to keep their breast. But in reality, the patients felt only 7% of the time that this was important. If you go to the next bar graph, you can see they were also asked, how important is it to you to live as long as possible? 96% of the providers thought, of course, that would be one of the top 3 concerns, but in fact, the women stated only 59% of the time that that was one of their top 3 concerns. And then if you go to the third bar graph, avoiding breast prosthesis, the doctors thought this wouldn't matter at all to women, so 0% voted for that, whereas a third of women considered that one of their top 3 concerns. So if we go back to the keep the breast, 71% versus 7%, so that is a 64% discrepancy between what the provider assumed the patient's values were and what her actual values were, which you can imagine if we were in business and we misread our customers to that extent, we'd be thrown out on the street, right? We'd be out of a job. So the point is that without asking that question directly, there's absolutely no way to know what a patient cares most about. So what does that look like? Let's move on to slide 19. I think the most important thing is to become better listeners. We talk about active listening, and this is the Chinese character, that the ancient Chinese character for listening, which is composed of multiple things. It's got an ear, which we obviously need. It's got an eye, so we can read all the nonverbal messages the patient is sending. It's got a heart, so we can really feel what the patient is transmitting to us. And it's got a line for undivided attention, which is what active listening requires. And the biggest challenge here is that one thing that clinicians tend to do is impose their own values on a patient. And they do it without any malicious intent. They don't even recognize they're doing it. So it's key that you've got to be non-judgmental, listen, and listen also, and look for the emotions underlying the words. And sometimes you have to give people permission to say, well, some people prefer this option, whereas others prefer that option. Either one are reasonable options. And then once they've told you what they care about, you want to make sure you ask what else, because they may have more than one value that's important, and sometimes they have conflicting values, and we'll come back to that. So if we move on to slide 20, this is a wonderful picture that to me represents beautifully the 2 different voices in medicine. So if we look at the clinician's voice first, we get trained in a culture of medicine, which I know many of you are familiar with, which is quite a foreign culture to patients. And we have been trained to a fault to diagnose and fix, which means sometimes we don't listen so well and we don't pay attention to what a patient is really asking us. Patients, on the other hand, come with their unique experiences, often have very different perspectives than ours. Their cultures are important to them. The stories that make up their lives are important. And so there's a major discrepancy between those 2 cultures, which needs to be bridged in order to do this well. If we turn to slide 21, the language that we recommend using to elicit patient values is to be very explicit. We have a decision to make. What role do you want to play? And we're asking that because, as you recall, 4% of people, 4 in 100, do not want to be involved in the decision-making process. And if they tell us that, that's fine. Then we're done. I have often been told that, though, and then the more information I've shared with the patient, the more engaged they've become. So I don't take that no fully at face value any longer. I say I'd still like to inform you, and if there's anything else you want to weigh in on, please let me know. Often there are others that a patient wants to be involved in making a decision, maybe a spouse, a partner, parent, or child. It's important to have them in the room as well. And then ask, what's most important to you in making this decision, and what else? So those are the questions that we recommend that people ask routinely. Okay, I'm going to now turn over the next portion of the presentation to Calvin to talk about risk communication.
Thanks so much, Nan. So we're going to move on now to slide number 22, which is our third objective, which is demonstrate how to use risk communication and decision aids. And what Nan was saying earlier in the talk about thinking that we do shared decision making all the time and realizing that we didn't, I was in the very same boat. And it is this very next section which opened my eyes and let me know that I wasn't as sharing the decision making as much as I thought I really was. Going on to slide number 23, defining risk communication as the open, two-way exchange of information and opinion about risk, leading to better understanding and better decisions about clinical management. I don't think that any of us disagrees with this idea that we want to open up the lines and make certain that the communication is as free and open as possible so that our patients can make their decisions and understand what's going on with them much more effectively. Turning to slide number 24, here are 4 important reasons why effective risk communication is important. First one is that quantitative risks are rarely discussed with patients, and I'll get to that a little bit more on the next slide. It's hard to translate research that's happening, and the research changes over time. So it's hard to make certain that what we're telling a patient in any one given moment may be the most current. People tend to overestimate benefit and underestimate risk without numerical data. So if I were to say to you, I really recommend this treatment because most of my patients like it, or the recommendation is that you do this treatment, unless the patients really have a quantitative idea of what that means, they may or may not want to adhere to what the provider is telling them. And finally, patients who receive more information are more satisfied and adherent to their treatment. So if patients really know what's going on, they're more likely to get on the program and stay with it. So right now we're going to move to the second polling question, turning it back over to Lynn.
Thanks, Calvin. Our second polling question is coming up on your screen now, and the question reads, the likelihood of developing an ulcer after taking this medicine is rare. What frequency are you trying to communicate? Please select one of the following responses. Less than 0.1%, 0.1 to 1%, 1 to 5%, 5 to 10%, or 10 to 25%. So you're giving us what do you mean by this likelihood of this happening is rare? Less than 0.1, 0.1 to 1, 1 to 5, 5 to 10, and 10 to 25. The likelihood of developing an ulcer after taking this medicine is rare. What frequency are you trying to communicate? What is your definition of rare? We'll give it one.
Or medium rare.
Seconds. So medium rare, medium rare. What temperature? Give a few more seconds. It's a really interesting question, actually. In different worlds, in the medical world, what does rare mean? Okay, we're getting a good response here. Thank you so much for your input. All right, let's close the poll. And we have The range of responses to the likelihood of developing an ulcer after taking this medicine is rare. What frequency are you trying to communicate? 14%, less than 0.1. 34%, 0.1 to 1%. 1 to 5%, 41%. 5 to 10, 8%, and 10 to 25%, only 2%. So Calvin, what do you think?
I think this distribution is very similar to distributions that Nan and I have seen when we have done this talk at various other places. And that is, first of all, that most folks are kind of less than the 5% range. The second thing, however, is that even if we take the lowest number on the topmost, at 10 to 25%, if we just take 10% there, and the topmost one on the top one, so 0.1%, that is a 100-fold difference, a 100-fold difference at the very least in this audience when we say rare.
Right.
What does that actually mean in terms of when we're saying that to our patients? It's rare. Our patients may be thinking it's less than 1% or it's 10%. And that difference is startling and it's illuminating, because what we're saying when we give a qualitative descriptor instead of a number, we're laying ourselves open to the possibility of misinterpretation. So moving then back to the presentation slide number 26, this gets at the idea of statistical illiteracy. And this is nobody's fault. It's just that it happens all the time. We're unable to understand the meaning of numbers. This is true of patients, this is true of journalists, and this is true of clinicians. I can say that it took me many, many years to really figure out what it meant when these numbers are thrown about in the media. I'll give you a recent example of lung cancer screening. About a year ago or so, people were talking about how various screening agencies were recommending the use of lung cancer screening. And you would hear different numbers. You would hear that lung cancer screening reduces lung cancer mortality by about 20%. 20% sounds like a lot. And then you dig into the data and you find out that the absolute risk of lung cancer screening, the decrease in mortality, is 0.33%. How is that possible that people are saying 20% in the media, and yet the actual number is less than 1%? This is why statistical illiteracy is rampant, is because sometimes we're given these numbers and we can't really make sense of them unless we really look at the original data. This is created by non-transparent framing of information. It could be because we don't really understand, but it also could be an intentional effort on the part of paper writers, the media, whoever, to persuade people toward an intervention that they otherwise may not want. And clearly this has serious consequences, not just for health of folks. For example, one of the most common side effects of lung cancer screening is going after a lesion that is not cancerous, but having to undergo many different tests and biopsies in order to determine that. It also has consequences for healthcare costs as well. Moving on to slide number 27. And this is talking about clear risk communication involving 6 different steps. We're not going to talk about each of these steps in detail given time. When Nan and I have done this in the past, we have done 3-hour workshops, sometimes longer, in order to coach people on the communication skills that are necessary in order to teach people how to communicate risk very, very clearly. But I would like to go through an example with you, combining some of these ideas of clear risk communication here. Slide number 28 gives us the case of a 65-year-old woman with 2 risk factors for osteoporosis. And this tool, called the FRAX tool, allows us to calculate online what the 10-year probability of that woman having a bone fracture is. So if we just plug in the white area on the slide, just plug in her demographic information, her age, sex, weight, height, whether she smokes, whether she's taken steroids in the past, etc. And you kind of press that calculate button on the right-hand panel in the middle there, calculate. The program calculates her actual percentage of having a bone fracture in the next 10 years. The risk of her having a major osteoporotic fracture is about 19% over the next 10 years. And the risk over the next 10 years of her having a hip fracture is about 5%. So for those of us who are statisticians, clinical researchers, maybe accountants, that makes sense, might make sense. For most of the rest of us, 19% can be a very confusing number. What does that actually mean? What does that actually look like? So rather than leaving the patient hanging there with just this idea of a number, what can be very, very helpful in addition to that is to describe things in terms of graphics. So on slide 29, you see the risk, a graphical representation of the risk of this particular patient having a bone fracture over the next 10 years. And you can just see that there are the white bones, which is the ones without fracture, and the brown bones, which are the ones with fracture. And you can see much more intuitively, particularly if you're a visual learner, what the risk of this patient having a bone fracture is over the next 10 years. It's just more intuitive if you look at it this way, 1 out of 5. Then moving to slide 30, this also gives us a sense of whether medication, taking a bisphosphonate like alendronate, would help decrease the risk of bone fracture over those 10 years. Now, in my practice, I used to say to a patient like this, it seems like your risk of having a bone fracture over the next 10 years is high. You should probably take this medication. Again, using the word high, don't know exactly what that means. And without really going through the data, I'm in a way forcing that patient into taking this medication because of my opinion. Instead, on this graphic, this depicts what the current data show. And that is that of the 20 patients who would have had a bone fracture, 8 would have avoided one because of taking the medication. 12 people will still have a fracture within the next 10 years. So that circle, that yellow circle, depicts the number of patients just like that 65-year-old woman who will have avoided a fracture because of the medication. And that's a much more clear representation of what the actual benefit of this medication is versus my just describing to a patient whether I think they should or should not take this medication. I'm hoping that that's making sense to you as you're looking at this slide. So at that point, I would, on slide number 31, I would check in with the patient. I would then ask, what do you think about the benefits of taking medicine to decrease a risk of a bone fracture? And just let the patient know this is truly shared decision making. I'm giving you the data as I know it, and I'm going to give you the opportunity to say whether the benefits of this medication in the yellow circle are worth it to you over the next 10 years. If the patient says, I'm not interested at all, it looks like too small a risk for me, too small a benefit for me, then I might just stop there. If the patient says to me, well, I'm not exactly sure what are the side effects of the medicine, or maybe I'll go ahead with this medicine, then we can move forward to the next step, which is on slide 32, which is the downsides of taking the medication. So on the top part of the slide, it says this medication has to be taken on an empty stomach once a week, 8 ounces of water, you have to sit upright. And then the possible harms, the possible side effects in terms of abdominal problems, osteonecrosis of the jaw, which is a very painful side effect in just sores, bone sores in the jaw. And then it also talks about the cost. And then, now that the patient has both the benefits and the risks clearly outlined, now I can ask the patient, well, what would you like to do now? So what I've just gone through with you is what we call a decision aid. It allows it gives graphic representations of risks and benefits of various clinical entities and potential treatments. And it gives up-to-date information on what the benefits and risks of taking that medication are. This particular decision aid came from the Mayo Clinic. There are many, many different other sites for decision aids that I'll get into in a moment. On slide number 33, decision aids, these are tools that are high quality and that give balanced information on the options and benefits and risks and allow patients to help clarify what their values are and then communicate them to us as their providers. The most important thing about these decision aids is that you can't just give that patient a couple of sheets of paper with those bones on it and expect them to make a decision without talking them through it. They're just an adjunct to our counseling. We need to be there, present with them, understand what the data are, and guide the patient through this decision-making process so that we're certain that their values are taken into account. The International Patient Decision Aid Standards Collaboration is a group of research from across the globe which evaluates decision aids as they come up. They themselves make and use decision aids, and they are able to rate the viability and the utility, and the effectiveness of any given decision aid. So it's not, you can imagine that there may be a lot of decision aids proliferating out there that are not vetted, and the IPDAS helps to codify some of those decision aids. On slide number 34, talking about the effectiveness of decision aids in a Cochrane review, lots and lots of data, over 115 randomized controlled trials, show that these decision aids improve knowledge, more accurate risk perceptions, increase patient involvement in decision making, improve expectations, leave fewer patients undecided, and increase agreement between patient values and what their choices are. So these are really, really helpful adjuncts to our ability to make shared decision making happen. On slide number 35, the Ottawa Hospital Research Institute also has accumulated a whole bunch of patient decision aids. If you go to their website, you can look at patient decision aids by specific condition alphabetized, and you'll be able to see these are not vetted necessarily by IPDAS, but it gives you a sense of the vast range of decision aids that are available to us. The other way, if you forget Ottawa Hospital Research Institute, the other way to access patient decision aids, and one that my residents use often, is Google. If you look at decision aids for a particular condition on Google, interestingly, oftentimes they'll come up and you'll see that the most commonly used decision aids and the ones that are most vetted come up near the top of the Google searches. So that's also an adjunct to our ability to refer to these decision aids. On slide number 36, one next step in terms of understanding whether or not shared decision making is actually happening in our practices. On 36, whether these is actually happening in our practices is the development of a very, very short and sweet, or as Glenn Elwyn, who developed this tool, puts it, a fast and frugal measure of shared decision making, whether or not effort was made in explaining, in eliciting preferences, and integrating preferences into an ultimate decision. So there are many, many more possibilities for shared decision making to happen in the future. Slide number 37 goes through this concept of decisional conflict, which I'm just going to gloss over briefly, just to give you a sense that just because we're sharing the decision with patients doesn't always mean that there are going to be up front with us if they are wondering themselves about what decision to make. Slide number 38 gives a couple of ideas of why decisional conflict happens. One of the most common ones that I get is this very last one. What do you think I should do, doc? Well, once upon a time when patients used to ask me that, I used to say, well, what I would do is this. But that's not respecting what the patient's values are. That's respecting my values. So nowadays, I follow up that question with, well, what I would do in this situation really respects my own values, but not yours. So I'm wondering what matters to you in terms of making this decision. So patients may have conflict about making an ultimate decision, and it's up to us to figure out what their conflict might represent. Slide number 39 goes on to the last objective, which is discussing resources for and barriers against shared decision making. Here's a table just to let you know that clinicians can be the repository for shared decision making, but there are also possibilities for decision coaches, that is, allied health professionals, other members of the team, ancillary providers like medical students, for example. If they're trained as decision coaches, they can be brought onto the team as people who can aid in the decision-making process without necessarily interfering too much with provider time or taking up the clinician needing to take a lot of time to do the counseling. That's one of these things that's evolving over time in terms of shared decision-making. I'm going to turn over the rest of the talk to Nan to take it home.
Great. Thanks, Calvin. I know we don't have a lot of time left, so let's get through these quickly and leave some time for questions. So to summarize what we've gone over, I think the really key point is that in any clinician-patient interaction, we have two experts in the room. The clinician is the expert in the options available for a given decision, what the risks and benefits are related to those options. And the patient is the expert on what matters most to them. What do they care about? What will their life circumstances dictate? What are their preferences? And the goal is to balance both of those things in any decision that gets made. If we go on to slide 42, there are a lot of resources here, and you can look back at this later and check out a lot of these websites. The first is a foundation that I mentioned. Mayo Clinic has done a lot of work in this area. The Ottawa Health Research Institute is listed next with that A to Z inventory, which is fabulous. Dartmouth, we're developing option grids, and there are a lot of other resources there that I encourage you to explore if you'd like to learn more. If we go to slide 43, I want to thank you, just as these two wonderful kids are sharing. We really hope that you all are sharing decisions with your patients in whatever capacity you work in healthcare. So our last slide, slide 44, is to really ask what barriers exist in your setting. And you can see the complexity of the mathematical formulas on this slide. One thing that Calvin and I and others have personally experienced is the complexity of really changing the culture of medicine to be more consistent with a shared decision-making, a truly patient-centered approach. So I'm going to now turn it back over to you, Lynn.
Back over to Beth.
Or to Beth, thanks.
That's fine. I mean, thank you, Nan and Calvin, so much. You know, I think that you must get this all the time, but I'm guessing that the most frequently asked question is, how do you do this in the time that we have allotted, particularly, you know, in a routine office visit? Can you just address that problem?
Sure, I'll take a stab at it. First of all, I think it's important to realize that decision-making is a process, and one isn't necessarily going to close the loop and finalize a decision in one visit. So I will often review options with a patient, hand out a paper-based decision aid like the one Calvin walked us through, ask them to review it with their family and loved ones and whoever they'd like to be involved in the process, and then come back next time. Or they may do that and call me up, email me, let me know some other way that they've made their decision and this is the route they want to take. So I don't think you're always going to finish it in one visit, but I think you're going to feel much more self-confident that you're helping them make a decision congruent with their values and circumstances.
That's very, very helpful. Thanks a lot, Nan. Lynn, were there other questions? Do we have time for some more questions from the audience?
Yes, and I have one, but I'm going to just remind our audience that if you have a question to submit, you may still do so. Just type your question into the questions pane, and we'll answer as many as we can in the time we have. I have a question about more from Calvin's presentation, although, Nan, you're welcome to start with it. It seems like the data in the media is very confusing, and rhetoric trumps fact in many of our worlds. And the question we have is, is there some kind of standard, like the food labeling standard that we have that come out of the government and food industry, of sort of some standards for how to display information that people can understand?
I'm happy to take a stab at that. So that is a really excellent point, and I think if you start reading medical journals or even the lay press, even the best of the lay press, like, say, the New York Times, they do a pretty lousy job of communicating risks and benefits. They typically use relative risk, which, as Calvin told us, overestimates the benefits of a given intervention. They will typically talk about benefits and not risks of a given screening test or intervention. So again, subtly coercing people towards doing what they want them to do. And there are a couple of researchers here at Dartmouth and around the world who are really working on trying to train the FDA, train journalists, and improve the way risk is being communicated. But it's definitely a work in progress. A lot of more needs to be done.
Excellent. Thank you. And could we, Kim, run our poll again? So now that you've heard from Nan and Calvin, what % of the time do you think that you spend doing shared decision making? We'd love to have your input now that you've listened to the presentation. 0 to 20%, 21 to 40, 41 to 60, 61 to 80, or all the time. And we're getting some good results in. Not quite yet. Give it a few more seconds. This is a great idea to do it again. Okay, Kim, I think we can close the poll. And what % of time do you spend, now that you've listened to our experts? We've got a little more even distribution, 20%, 40%, 60%, 80%, and very few said all the time. So, Nan, you want to comment on that?
Sure. So I'm glad people are being honest. And I have to say, I think you're a pretty exceptional audience, because the fact that you're still doing it, most of you, between 20 and 80% of the time, is fabulous. And I wish the whole world were working that way. I don't think we've reached that level across health systems yet.
Well, I think we've got a bunch of participants who listen very well. I have another question. How do you deal with patients or families that glean information from the internet that may or may not be relevant to the case?
That's a universal problem we all have, and I actually applaud my patients for reading and trying to educate themselves. I think that's the most important message to get across. I try and provide them with what I consider to be reliable internet-based sources of information, and tell them that there's a lot of garbage on the internet that they need to avoid, and obviously you're not going to believe everything you read. So I really try and steer them towards excellent information and encourage them to be actively involved. Calvin, do you want to respond as well?
Yeah, and I would agree with all of those things, and sometimes I'll ask patients to take me to the site that they learned it from. And I've actually learned a couple of things or two from some of my patients who said, I heard this and I didn't know about it, and they directed me to a website that's, the National Cancer Society website or something like that, and it's there. So it gives me an opportunity to exercise my own professional humility, that there's no way that I can know everything, and I want my patients to be able to participate in that process.
Very helpful. I think we have time for one more question, and I'm going to ask, how do you handle the situation where the patient and the family disagree?
Well, this is where the conflict management training that I have helps me out. I'm not going to be able to give a very short answer to this, but I do think it's critically important that everybody agree that it's ultimately the patient's decision. I know it gets a lot more complex than that at times. There have been a few times when there's been such an active disagreement that I've asked other family members to step out of the room, and so that I can engage more fully with the patient without constant interruptions. And I also applaud the family for caring so much about the individual. So you're trying to give them positive feedback, and you're trying to help them recognize that it's the patient's values that are the most important consideration.
Wonderful. Thank you so much. This wraps up our Q&A session. Beth, any final thoughts you'd like to share with our participants?
I actually, if there's time, Nan, I know that you prescribe decision aids to your patients, that you have a way of actually doing that, and I wondered if you could share that with the listeners just quickly.
Yeah, I used to have a way of sharing the best decision aids on the market, and now because our research funding is ended and the financial landscape is changing, I do not have access to those any longer, which is unfortunate. So typically what I've done is I've gone to that Ottawa Health Research Institute to find decision aids. I have a lot that I have sitting on my screen ready to roll out at any moment, but nowhere near enough to help me with every decision that I'm counseling patients about. So one of the major challenges we have in this field now is that we really need to have a better stable and better organized way to distribute decision aids. And I hope CMS will work on that. Medicare and Medicaid will be working on that.
It's certainly needed, but thank you for supplying the list of resources so people can take a look for themselves and maybe download the ones that are available and that they would use commonly.
Yeah, and I just want to interrupt for a second, Beth, and say that to our participants that we will make these materials available to you on our website. So a number of questions have asked about that. So we will have that material available for us. I'd like to thank Beth for hosting, and Calvin and Nan for sharing their expertise and insights with us, as well as everyone in the audience for setting aside time in your busy day to participate. We hope that you'll join us for upcoming programs in the Schwartz Center for Compassionate Care webinar series, including Family Meetings, Improving Family Clinician Communication on October 19th. And there's a slide. There it is. Thank you. Please keep an eye out for our invitation emails. Beth, do you have any final remarks?
Well, I just want to thank everybody for attending, and especially thanks to Nan and Calvin for an excellent presentation. Really appreciate your time and thoughtfulness.
Great. Thank you.
Thank you so much. We know how busy you are, but we'd very much appreciate you taking a moment to complete the electronic survey upon exiting today's program, as we value your input and are planning for our next season's programs. Thank you all, and have a terrific day.